All right. Well, how about if we get started? Welcome, everybody, and thanks for sharing your time with us here at CELA Speaks. I'm going to step in for Jan McAllister this evening and introduce our speaker. We're very fortunate to have Dr. Mohit Khera, who's an MD, an MBA, and an MPH, a unique set of credentials. He is the F. Brantley Scott Chair in Urology at Baylor College of Medicine. He's a world-renowned urologist with expertise in sexual medicine and testosterone therapy. And I first learned of him in listening to one of the Peter Attia podcasts. So we're really in for a treat this evening. And I will turn it over to you, Dr. Khera.
Great. Thank you so much for the introduction, and thank you for this opportunity. Tonight, I'll be discussing practical tips on testosterone replacement therapy. If you've been following this space over the past 10 years, there's been a complete paradigm shift on our understanding of what's safe, what's effective, and what I'd like to share with you tonight. These are my disclosures. I do consult for companies that make testosterone products, but I have also been involved with a Traverse trial. The Traverse trial was just published in June of this year. It's the largest randomized placebo-controlled trial ever published in men with testosterone. I'd like to share those results with you this evening. So let's get started. So when we think about testosterone, a lot of the people think, it's about muscle mass and libido and sexual function, but it goes actually far more than that. Testosterone has a very large impact on many parts of the body in terms of our liver and how we make our proteins. Extremely important for osteoporosis and osteopenia, not only in men, but I treat a lot of women with testosterone. It's very effective in women as well. It's very important for spermatogenesis, but that is endogenous testosterone. Many people don't realize that exogenous testosterone is a natural contraceptive. So you would never give someone testosterone who wants to conceive or have a child. So again, we use medications to raise endogenous testosterone. And then do understand that some percentage of patients who take testosterone will develop erythrocytosis. And part of that mechanism is the stimulation of erythropoietin in the kidney. So again, many effects of testosterone. It's not just about libido and erectile function. So there are many conditions that are associated with low testosterone. And one of them is chronic opioid use. And many people don't realize that the number one cause of low testosterone is chronic opioid use. Up to 74% of patients who take opioids will see a significant reduction in testosterone. And this can be seen within 4 hours after the ingestion of an opioid. And the mechanism is really a double hit. It not only suppresses LH secretion from the hypothalamus, from the pituitary, but it also decreases Leydig cell production of testosterone. Many other conditions, diabetes, obesity, AIDS, also associated with low T, hypertension, hyperlipidemia, 40%, and ED, about 20%. So I do give this talk frequently to primary care physicians, and I do tell them, look, you're seeing these patients in your clinic. These patients really should be screened. So how do you diagnose low T? It's pretty easy. You just need a blood test, and you need the signs and symptoms. The blood test that we use today is 300 nanogram per deciliter. Now, I'll just tell you that number is somewhat arbitrarily made up. There is not great data to suggest where we came up with 300. It came out in the 2016 Endo guidelines. And so some of us have changed the number to 350, and some of us only use free testosterone because it tends to be much more accurate. And then, so the point here is that if a patient has low testosterone, but they feel great, they have good energy, good libido, no issues with sleep, muscle mass, we leave them alone because you have to have both. And conversely, if a patient has all the signs and symptoms of low T, but the testosterone level is normal, it's 500, you don't treat them. You have to have both the signs and symptoms and a low blood test. So what are the signs and symptoms? Well, increased body fat is very common, reduced muscle mass, low bone mineral density. There were several studies showing that men with lower testosterone levels are much more likely to have a fracture, and that is true. There are numerous studies also suggesting that giving testosterone increases bone mineral density as early as 6 months. So I really can't stress the importance of checking testosterone levels in men who have a fracture and considering testosterone supplementation in hypogonadal men who have osteopenia or osteoporosis. Some of the symptoms we see are decreased energy, decreased libido, very common, erectile dysfunction, diminished work performance, poor concentration and memory, sleep disturbances, and depression. And I think the depression one is very important because not many of us think of low testosterone when we think of depression or vice versa. And in 2011, we published a study. This is a registry study looking at 849 men who had low testosterone that were given testosterone gel. And we administered the PHQ-9, which is a validated questionnaire for depression. In this study, 92% of men who had low testosterone had some degree of depression. That's a lot. 92% had some degree of depression. 17% had severe depression. We treated these men for 1 year, and we found the severe depression significantly declined from 17% to about 2%. But what was so interesting about this study was that if a patient was already on an SSRI or an antidepressant, and you put them on testosterone supplementation, there was also a significant improvement in PHQ-9 scores, suggesting there may be some synergy between SSRIs and testosterone. So I don't want anyone here tonight to think that I'm advocating to treat major depression with testosterone. But what I am asking for is that if you have someone who's depressed, you should at least check their testosterone levels. So how do you diagnose low T? There are questionnaires that you can use out there. The questionnaires have very poor sensitivity and specificity, but the number you want to remember right now is 300 nanogram per deciliter. It's important to check other hormones. Many times it can be hypothyroid, because if you look at the symptoms of hypothyroid, they're very similar to patients who have low testosterone. So you just want to check for the other conditions as well. Remember that testosterone slightly declines as men age, slightly. But what does go up as men age is SHBG, sex hormone binding globulin. And remember that SHBG binds testosterone very tightly. So the higher the SHBG, the less the free T. And so, many patients, as they get older, the free T goes down quite quickly, even though the testosterone may be not that low. So the patient that comes to me that has a testosterone of 400, he's 74 years old, you want to check that free T because it may be the free T is low. Many patients say, look, doc, don't give me any testosterone, just lower my SHBG. I say, I can't do that. There's not a drug necessarily that can do it. Now, giving testosterone can actually lower SHBG, but usually SHBG is associated with medical conditions. Liver disease, hyperthyroid increases SHBG, nephrotic syndrome can decrease SHBG, glucocorticosteroids can decrease SHBG. So just good to know if someone has a very elevated SHBG or a very low SHBG to look at the factors or conditions that could be affecting that. I like to calculate my own testosterone. I don't like to use an assay. All I do is I order the SHBG, I order the total testosterone, we put them in these calculators, and we calculate our own free testosterone. And this is much more accurate than getting a free testosterone assay. So again, calculated free T, and our lab does this internally for us. So just a reminder of the production, from the hypothalamus releases GnRH, GnRH goes to pituitary, secretes LH and FSH, those go to the testicles, FSH induces sperm production, LH induces testosterone production. There is a negative feedback that does occur with this, but this is the main, we call the HPG axis. Diurnal variation is important. We know that when men wake up in the morning, they have their highest level of testosterone. When they, later in the day, the levels go down. Remember that this diurnal variation is muted between the ages of 40 and 50. So if a man comes in, he's 65 years old, I don't expect a lot of variation. If he's a 30-year-old man, I do expect some variation from morning to evening. And that variation is about 30%, because we can't always control what time they come into the clinic. So if they come into the clinic at, 4 in the afternoon and you want to check the testosterone, at least a lot for the fact that this could be 30% lower than it would be in the morning. So I want to talk briefly about some controversies with testosterone therapy, about oral testosterone, indications for testosterone, testosterone in the prostate, testosterone cardiovascular risk, and fertility. So something interesting happened in the United States. Oral testosterone is now available in 2019. We have that available. It's been available throughout the world since the 1970s, but it wasn't until 2019 when we got it in the US. But it's an old drug. I mean, actually, testosterone was first synthesized in 1935 And the first oral testosterone was made in 1935. But the problem with those testosterones was that they were methylated, because if they didn't methylate it, it would get degraded by the liver. And so when they methylated it, the problem was when it went through the liver, it used to cause significant hepatotoxicity. And that's because it was methylated at the 17-alpha configuration. So in the 70s, they came out with testosterone undecanoate. It goes through the lymphatics. It bypasses the liver. And this essentially can cause a significant improvement in the serum testosterone without affecting the liver. And this is just a schematic looking at taking an oral medication, bypassing the liver, going through the thoracic duct into the bloodstream, and much, much safer than taking other conventional oral testosterones. This was Andriol. It was available in the 1970s throughout the world, never made it to the US. Started in 2022, the 45th anniversary. This was Andriol. The problem with Andriol, the original orals, was it had to be taken 3 or 4 times a day with a fatty meal. And so that can be a little bit of a hassle, taking it 3 to 4 times a day with a fatty meal. But this is taking it with a meal, without a meal. If you take a look at the red bar, that's with a meal. If you look at the white bar below, it's taking it without a meal. If you don't take food, it doesn't get absorbed. And then no hepatotoxicity was noted with these orals because it bypassed the liver. So Jatenzo was the first one that came out. It's available right now. It came out in 2019. And this one, if you look at the curves, it does show that there's 2 big curves that are curved throughout the day. It's a BID dosing. But I prefer to give the patient this medication at breakfast and lunch and really have most of the peaking going on during the day and not when they're sleeping. There is some hypertension associated with these. I think that all testosterone causes hypertension, but the FDA required hypertension testing at 2015 and onward, and it's about a 5 millimeter increase in systolic. One of the benefits of oral is that it has a decreased rate of erythrocytosis. So remember that one of the problems with testosterone is it can cause erythrocytosis. And if it gets, the hematocrit gets above 54%, there's some concern that that may be a cardiovascular risk factor. So, the injectables can cause erythrocytosis up to 67%, but the orals are less than 5%. So you may want to switch somebody from an injectable to an oral if they're having a recurrent erythrocytosis on these medications. So as I mentioned earlier, 2019 was the first one, but now in 2020, 2 more oral testosterone products came out, Tlando and Kaisertrex. So again, we have 3 orals on the market. What about indications for therapy? So this is important. In 1981, the package insert for all the testosterone products had something called class labeling. And it read androgens are indicated for replacement therapy in conditions associated with a deficiency or absence of endogenous testosterone. And they list primary hypogonadism and secondary hypogonadism, and they list conditions. And then there's this word called idiopathic in there. Well, nowhere do I see the word erectile dysfunction in here. Nowhere do I see the word low libido. So if they had low libido or erectile dysfunction, I would say that this was idiopathic. Well, in 2015, the FDA said that they cautioned testosterone products are only approved for men with low testosterone levels caused by a certain medical condition. And the benefits and safety of these medications has not been established for the treatment of low testosterone due to aging. And so what they did in the package insert is all they did was cross out the word idiopathic. And since they crossed out the word idiopathic, now they're saying if you want to be on label for treatment, you have to have a true medical condition like a pituitary tumor or a testis tumor. So just remember that 85% of the patients we treat today are considered off-label. The guidelines are a little bit different. The guidelines say this is ridiculous. You don't have to have a medical condition to treat a patient. You just have to have low testosterone and signs and symptoms. So here we find a discrepancy from what the guidelines say and what we actually, the FDA is saying in terms of ability to treat a patient. Erectile dysfunction, I was fortunate enough to be involved in the AUA guidelines in 2018 for erectile dysfunction. And a patient comes in and we offer them 5 treatment options. It could be a PD-5 inhibitor, vacuum, suppository, injection, phenylprosthesis. Nowhere do you see the word testosterone here. So testosterone is not a treatment for ED. Now, when the patient comes in for ED, we're supposed to check hemoglobin A1C, testosterone, lipid panel. So why are we checking the testosterone if we're not going to treat it? And there's a reason for that. When we were on the guidelines, we found numerous studies suggesting that combination therapy with PDE5 inhibitors and testosterone are much more effective than using these PDE5 inhibitors alone. So we checked it for the testosterone level because we may need to use it with a PDE5 inhibitor. Okay, what about prostate cancer? This comes up all the time. Patients say, I Googled it and I heard that I can get prostate cancer. And this is a survey that came out in 2006 saying, what's your number one concern? Number one concern was, I can cause prostate cancer. Number two was BPH. So there's this paradigm shift that occurred over the past 20 years where when I started my residency 23 years ago, we were taught that testosterone is dangerous. And then we started thinking it was safe. Now we're thinking it may be therapeutic and maybe protective. And I want to share that with you. These are some of the first studies looking at patients with high-grade PIN. These are risk factors for prostate cancer. There was no significant change in PSA. None of the patients progressed. These are the ones that received testosterone. So again, early studies suggesting no increased risk. But there have been numerous other studies after this, giving men testosterone after radical prostatectomy, radiation, and they also found no significant increase in prostate cancer recurrence in men receiving testosterone after prostate cancer therapy. I want to share with you a study that we published. This was in 2013, where we gave men with high-grade prostate cancer testosterone, and we followed them. They had high risk as well. And we had a control group that did not receive testosterone. And what we found was that those men who were high risk that received testosterone, their biochemical recurrence was only 15%. If you were high risk and did not receive testosterone, your biochemical recurrence rate was 53%. It was significantly higher. So many said, look, are you suggesting that giving testosterone may be protective because your recurrence rate is so low in those men receiving testosterone? And there are some studies. This is out of my lab, and these are very fascinating studies. We took Petri dishes of prostate cancer cells, and I put different amounts of testosterone in each one of these Petri dishes. And you can see, and it doesn't matter which bar you look at, is that initially, if you give testosterone, you do see a significant increase in prostate cancer cell growth. But as you give higher and higher doses of testosterone, you get greater and greater suppression of prostate cancer cell growth. And I call this the inverted U, where maybe castrate may be protective, and putting the patient in the normal range may be protective, but the middle range is dangerous, the hypogonadal range. These are just looking at cells in A, B, and C. A is looking at no testosterone, B is giving testosterone, and then a low dose, and then C is giving high dose testosterone. And you can see that high doses of testosterone suppress prostate cancer cell growth. We did some animal studies as well. I took 200 mice with normal mice, orchiectomy plus low dose testosterone, orchiectomy plus high dose testosterone. And we injected LNCAP cells on the back. These are prostate cancer cells on the back of these mice. And we followed them for almost 3 months. So this is the testosterone going under the skin. This is the cancer growing on the back. We measure the cancer. And what we found was exactly the same thing. Those, when you do an orchiectomy, you drop the tumor incidence rate. Low dose testosterone increases the tumor incidence rate, and higher doses drops the tumor incidence rate again. So this inverted U concept is what we see again. Many case control studies, large studies showing that giving testosterone does not increase the risk of prostate cancer. In fact, this large study showed that patients who received testosterone had lower risk of aggressive prostate cancer. And I think that's important. Tom Allering did a very interesting study where he took men after radical prostatectomy. He had 152 low-risk patients with no evidence of disease, followed the median of 3.5 years. And what did he find? He gave them testosterone. What did he find? Cancer occurred in approximately 7.2% of patients treated with testosterone, whereas cancer had occurred in 12.6% of patients who did not receive testosterone. So in other words, giving that patient testosterone delayed the biochemical recurrence by 1.5 years, or absolutely decreased the amount of biochemical recurrence. So that's That's a totally different paradigm to think about testosterone as a protective measure against the development of prostate cancer. So talking about biomarkers, testosterone has been shown to be a great biomarker. Low testosterone is a predictor for who can have prostate cancer. Low testosterone is a risk factor for biochemical recurrence after prostate cancer. These are all very important, but I think the most important study I want to share with you today is the BAT trials. The BAT trials are so important. They came out in 2015. And do you know, if you had metastatic prostate cancer today and you walked into Johns Hopkins, one of the ways they treat you is with high doses of testosterone. And this is their first study in 2015. 14 men with castrate-resistant prostate cancer, gave them high doses of testosterone. They call this BAT therapy for 3 months. There was a 50% reduction in PSA and a 50% reduction in metastatic disease. Quite impressive. But their more interesting study was the Transformer study that came out in 2021, where they gave men either BAT therapy or enzalutamide, which was the standard of care in men who had castrate-resistant prostate cancer. So essentially, they said, look, you've failed abiraterone, you have castrate-resistant prostate cancer, you're supposed to get enzalutamide, but I'm going to randomize you to get enzalutamide or high doses of testosterone. And they looked at prostate cancer and they looked at progression-free survival. And if you look at the graphs, it's amazing. It didn't matter whether you got testosterone or you got enzalutamide, which is standard of care, the survival was the same. Now, in this study, they allowed you to cross over. So if you got testosterone, you could switch to enzalutamide if it failed. And if you got enzalutamide, you could switch over to testosterone. And in those patients, excuse me, who received testosterone and switched to enzalutamide, they actually had greater survival than those patients who had enzalutamide alone. Remember, we weren't the first to think of this. Huggins and Hodges thought about this in 1965, where they talked about the fact that giving testosterone may be used for therapeutic benefit as well. The AUA guidelines still say that, there's no link between testosterone and prostate cancer, but if someone has a history of prostate cancer, we still need more studies to be done. And then finally, about BPH, enlargement of the prostate. If you look at the package insert on these testosterone products, they say that you should be careful because it makes your urinary symptoms worse. I just want to be clear, there's no data to support that giving testosterone makes urinary symptoms worse. In fact, if you look at the largest study looking at testosterone and BPH, all the outcomes, if you look on the far right, show that either testosterone has no effect on urinary symptoms or improves urinary symptoms over the course of 1 year. Now let's talk about cardiovascular disease, because this has got really interesting over the past several years. So, Molly Shores was the first to show that men with low testosterone levels are much more likely to die at an earlier age. This was in 2006. It was retrospective, but men with lower testosterone levels were much more likely to die at an earlier age. And since the Molly Shores study, there have been numerous other studies. These are now prospective, showing the same thing, that men with low T are more likely to die. And if you look at the cause of mortality, many of them were dying from cardiovascular deaths or MI. So that was very interesting. In fact, we did a study looking at all the articles we could find from 1940 to 2014. And we found over 200 articles looking at testosterone and cardiovascular disease. And 4 articles suggested that testosterone does increase cardiovascular risk. The majority suggested that increasing testosterone decreases cardiovascular risk. These are the 4 studies. I don't have the time to go through these 4 studies, but suffice it to say that most of these have no randomization, no placebo, no control. These are retrospective studies suggesting that testosterone may increase cardiovascular risk. So much so that the FDA in 2015 had a change in the package insert saying that there's inconclusive evidence to support that testosterone does not increase cardiovascular risk. And so this got the attention of many people. And after this came out, this warning, we looked at other studies also looking at cardiovascular risk and testosterone. And the other studies after that warning coming out also suggested no increased risk in MI with testosterone therapy. So just a small subset of articles suggesting that it may increase the risk. The guidelines are different. The guidelines say that low testosterone increases cardiovascular risk. That is true. And before, the guidelines used to state that if we give testosterone, we're not sure if that increases cardiovascular risk or not. But that's going to be changing soon with the new Traverse publication. So what is the mechanism? The mechanism really is where people start having erythrocytosis. And so just remember, if a patient does develop erythrocytosis, you can switch them from an injectable to a pellet or even a gel, and you can drop that rate of erythrocytosis. And remember, erythrocytosis happens slowly. It doesn't happen in a week or a month. Typically about 3 to 6 months, we start seeing the increase. So let's talk about the Traverse trial. Great study, randomized, double-blinded, placebo-controlled trial, men between the ages of 45 and 80. In order to qualify in this study, you had to have pre-existing cardiovascular disease or increased risk factors for cardiovascular disease, low testosterone. We originally started out with 6,000 patients. We wanted 6,000 patients, randomized to gel or placebo, but right now we have 5,200 patients, and it's up to 5 years follow-up. So here they are. These are the pre-existing cardiovascular disease conditions: coronary artery disease, cerebral vascular disease, peripheral arterial disease, or we could have 6 of the following risk factors for cardiovascular disease. So it's important to decipher this, but these are high-risk patients. So we wanted to have the patients that had the highest risk for having a cardiovascular event and seeing if testosterone made it worse. So the primary endpoint was any component of MACE. It's time to first occurrence for any component of MACE. Secondary endpoints are revascularization procedures, CABG, and then we wanted to look at prostate safety, the incidence of high-grade prostate cancer as well. These are some of the other secondary endpoints. There was 5 other secondary endpoints: sexual function, mood, depression, fractures, diabetes, and anemia. And these will all be published. Right now, we have the one on sexual function and prostate published, and cardiovascular and anemia. Those are all published. So testosterone supplementation did actually improve serum testosterone levels. And the testosterone arm, it was 148 nanogram per deciliter, and placebo, it was 14 nanogram per deciliter. And so this is looking at the endpoints, and this is probably one of the most important slides for this study. Testosterone did not increase MACE or cardiovascular events in those men treated with testosterone over placebo. But there were 3 surprises that we found. The first surprise was that there was a slight increase in pulmonary embolism, which I didn't expect. So it was significant. It was from 0.5% to 0.9% increase in pulmonary embolism. The other 2 surprises are that there was a significant increase, but not much, in atrial fibrillation and acute kidney injury. In other words, slight decrease in renal function, and also there was a increase in atrial fibrillation as well. So this is the results of the sexual function trial. So this was a subset of the large trial, and we had almost 600 patients in each arm receive placebo or testosterone. What they found was that there was no significant improvement in erectile function. So in other words, testosterone was not great as monotherapy in improving erectile function. But what it did do was it did improve libido, and libido was sustained after 2 years. So that's very helpful. Just finally ending on this, I just talked earlier about this feedback mechanism from the HPG axis, and testosterone is a natural contraceptive, and it will shut down the axis. So be careful. Other studies have shown giving 200 milligrams of testosterone weekly, patients are azoospermic within 6 months, and not everyone goes back to baseline. 46% of patients in this study were back to baseline, and an average of almost 7 months. So what are some alternatives? There are some medications you can use to make your own natural testosterone, and there's only 3: aromatase inhibitors, HCG, and SERMs. So if you remember the schematic, we have a feedback with testosterone that goes back to the pituitary and hypothalamus, and estrogen comes in here, and estrogen comes in and is a negative feedback, and it can actually block LH and FSH. So how do SERMs work? SERMs will sometimes block the estrogen receptor, and they will increase LH and FSH very naturally. Other ways to do this are diet and exercise. I really am a big proponent on diet, exercise, sleep, and stress reduction. I do think that lifestyle modification can make a big impact on testosterone levels. So we highly encourage patients to work on these 4 pillars: diet, exercise, sleep, and stress reduction. This is one of the best studies on weight loss. If a patient loses 10% of their weight, they'll see almost a 100 nanogram per deciliter increase in serum testosterone. If they lose, if you lose 10% of your body weight, it's 100 nanogram per deciliter. If you lose 15% of your body weight, you almost see about a 250 nanogram per deciliter increase in serum testosterone. So weight loss has a profound effect on serum testosterone. And many of these drugs you see out there, like semaglutide, we are using these drugs and we see profound effects not only on the weight, but increases in serum testosterone. So in conclusion, oral testosterone appears to be effective and safe with minimal increases in hematocrit and blood pressure and no hepatotoxicity. The majority of men being treated with testosterone are being treated off-label. Testosterone should be considered as a biomarker to better diagnose and treatment of prostate cancer. Testosterone has not been shown to worsen BPH or urinary symptoms. There's no convincing data to support that testosterone increases cardiovascular risk. And I think the lifestyle modification and serums are optimal ways to raise endogenous testosterone. Thank you for your attention.
Wow, that was a great talk. Appreciate all the information. I think that is definitely beneficial for all of us in clinical practice. Just as a reminder, if anyone has any questions, you can send your questions through the chat, or you can unmute your microphone and ask your questions.
I found that the Q&A sessions are really the most important for testosterone, because it's really hard to find like a book and read this stuff. A lot of it comes from, clinical practice, but I do think that testosterone, there is a bidirectional relationship between hypogonadism and metabolic syndrome. And if you look at patients who have low T, they tend to have a propensity to develop diabetes, obesity, and metabolic syndrome. And giving testosterone has been helpful in reversing metabolic syndrome in many patients. And I think that's just an important point.
How often do you recheck the testosterone when you're treating it?
That's a great question. So what we typically like to do, it depends on the formulation. There are 7 ways to get testosterone. It could be a gel, injection, a patch. But typically, if I use a gel, I'll have them come back in 2 weeks. If I use a pellet, then I'll have them come back the first month. If I use an injectable, I have a little bit different philosophy. I like to see the trough. I'm not so concerned about the peak. If the peak is too high, they'll get erythrocytosis, we'll deal. But if the trough is 150, that means for part of the week, they are suffering. Now, I do not believe in giving 200 milligrams every 2 weeks. That is a mistake. I think it causes a significant amount of erythrocytosis and too many peaks and troughs. And then we started giving 100 milligrams once a week. But quite frankly, the best way to do this, in my opinion, is to give 50 milligrams twice a week on Sunday and Thursday. Because remember that testosterone peaks in 24 hours. So if you give it to them on Sunday, they're ready for Monday. If you give it to them on Thursday, they're ready for the weekend. And we showed that if you split it, you decrease the erythrocytosis rate. So when you give it, I like to give lower doses more frequently. And on the injectables, I think you should check the trough.
Dr. Khera, you answered my exact question. I was going to ask you about the microdosing type regimens. And you're talking about sub-Q, by the way, right? Because we were all taught in medical school. I mean, I can remember giving the IM injections in my office long ago because nobody wanted to give the injections in the butt. And we were giving it, my God, more than 200 milligrams every 3 weeks long ago when I first started practice. So could you bring us up to speed on sub-Q dosing?
Yeah, so you're absolutely right. That it is FDA approved for IM dosing. And about 12 years ago, I was in a conference in Brazil. And in Brazil, everyone was giving the drug sub-Q. And I thought that was very interesting. And they said, look, it's less painful and has better absorption. And when I came back to the US about 12 years ago, I started doing sub-Q. And it is true. And when you do sub-Q, you got to drop the dose by about 20% because it's a very good absorption. So if you're using 100 milligrams IM, you should be giving 80 milligrams sub-Q. And it worked so well that several years ago, a company by the name of Antares came out with a medication called Xiosted. And all they did was take testosterone and anthate. They didn't invent anything. They have just a spring They invented a spring, and they put a testosterone enanthate in the spring, and it was FDA approved for sub-Q. So that is an FDA. So basically, enanthate is FDA approved for sub-Q and IM, depending on if you're using the automatic spring load or not. And I think that the sub-Q is less painful, far less painful, because we typically will use a 27 or 25 gauge. It's a little thick, but you can do it. And they just pinch the fat and put it into the fat once a week or twice a week. So it works, I think, much better, and it's less painful.
Any significant difference to you between the cypionate and the enanthate?
Yes, there is.
Okay.
So I tell the residents the way you want to think about this is cypionate has a C and enanthate has an E. And so C stands for child and E stands for elderly. And the reason why you do that is because cypionate is much more anabolic and has much more sodium retention. If you give an 80-year-old man cypionate, he's going to swell. He's going to get a lot of edema. So you want to give that man enanthate. So I kind of use 50 to 55, the kind of that cutoff range where I want to start moving over to enanthate, because I really don't want all that fluid retention in my older patients.
Wow. Let me keep the questions rolling. All of us, I'm sure, have had patients come in and say, well, what about this stuff I see on TV, Nugenics or whatever? They show some ex-baseball player walking down the street and they say, that you get it in capsules in a bottle, guaranteed to work. I think I know what's going on there, but I want to hear what you say.
Yeah, so first thing is first, one of the scariest things that are occurring in the United States, you and I today can make a product and we can put it on the shelves of GNC and no testing on efficacy or safety.
Yep.
That's scary. That is so scary.
Yep.
And so many times patients come into my clinic and they have suppressed LH and FSH, elevated prolactin, weird stuff, high elevated LFTs. And you stop their supplement and everything kind of goes back to normal. And that there's no testing. There's no way to show. So I say, look, unless it's tested or you can show me some research on safety even, then I am very uncomfortable with you starting these medications. But many of these medications have DHEA in them, or they have prohormones that will raise your endogenous testosterone, or they may have something like an aromatase inhibitor, so they can block the conversion from T to E, so your T goes up. Some of them will have even finasteride or some medication, because remember, testosterone is broken down to estrogen, 0.3%, and DHT, 6 to 8%. So if you block the outflow, the T goes up, or if you give a prohormone like DHEA, but those are not that I strongly disagree. I don't recommend doing that,
How about, here's a question from the chat from Chris Colts. Any hesitations about testosterone replacement in men with a history of prostate cancer? Any relevance to the type of treatment? Would that affect your decision making, where they have prostatectomy versus radiation?
So if you saw those slides, it was a huge paradigm shift over the past 20 years. When I first started, we were taught it was dangerous. Now we're at a level where we are treating metastatic prostate cancer with high doses of testosterone. Talking about a 180 here. So yes, so I do treat men with a history of prostate cancer. Radiation is a little bit different, because radiation, the PSA is not down to zero. There's always some PSA there. On a prostatectomy, when the prostate's removed, I know it's zero and I can follow it a little bit easier. So we do counsel, and remember, the guidelines say it is true, we don't have a single randomized placebo-controlled trial with testosterone looking for prostate in men with prostate cancer. So it's counseling, letting them know that there's no randomized placebo-controlled trials, but I don't have a significant amount of concern. In fact, I truly, if you want me to ask the question, I think that having low testosterone after prostatectomy increases your risk of having a biochemical recurrence. And if it was me, either castrate me, because there could be some benefit, or raise me into the normal range. But if you remember that inverted U, do not sit in the hypogonadal range.
How about those calculators for free testosterone level?
Yeah.
That slide came by pretty fast, but all we have to do is Google that, or you can
do it right now. You just put it, it's so easy. All you do in Google is put free testosterone calculator and it comes right up. And for albumin, unless they have some severe liver disease, put 4.3 every time. That's easy. It doesn't change it too much. All you have to put in there is just the SHBG and the total T, and it gives you a beautiful free T calculation. They even have on the app. So Apple, Android, and on Google.
I'm not sure, but what are the labs doing when they're giving us a free testosterone? They're not using this, obviously.
They're running an assay. They're running a free testosterone assay, which is not very accurate.
Okay. I remember you and Peter talking about that. Yeah.
There's another question here. Why use clomiphene AI instead of testosterone? Now, this is very important. If I give a 32-year-old man testosterone, I will be shutting down his sperm production, and I'll be shutting down his natural endogenous testosterone production. And if I do that for a long period of time and he changes his mind, I don't know if I can get him to start producing back to the level he started. So in a way, I'm kind of hooking him, making him kind of dependent on testosterone. He's only 32 years old. So we have at least 50 plus years to go. And that's a long time. So wouldn't it be great if I can use medications to make him make more testosterone, which would now only preserve his fertility and also not have him dependent on the drug? And so there's only 3 drugs: HCG, clomiphene citrate, and anastrozole. Now, the way clomiphene citrate works, it goes to the pituitary and raises LH and FSH. And when that LH goes up, it's like fuel to the testicles to make more testosterone. HCG bypasses the pituitary. It's just pure LH. So it just goes to the testicle and makes more testosterone. So in patients who have an elevated LH and FSH already, giving them clomiphene and HCG is not going to help because they already have an elevated LH. So that's not going to help. So the best example is Klinefelter's patients. LH is through the roof. Giving them HCG and clomiphene are not going to help. But giving that patient anastrozole will help, because what anastrozole does, it just simply blocks the conversion from testosterone to estrogen, so you get to keep more of what you're making, So the LH and FSH is the driver of whether you're going to use anastrozole versus clomiphene or HCG.
This is a somewhat related question, but I remember you and Peter talking about a post-finasteride syndrome, and I think a lot of us here are probably seeing more and more men coming in on finasteride. Could you dive into that a little bit?
Yeah, it's an interesting topic. So about 10 years ago, I got interested in this. There were a subset of men who were taking finasteride who, when they even stopped finasteride, they developed irreversible sexual dysfunction, depression, suicidal ideation, muscle wasting. And so, there's controversy. There are many, I'm the minority. I do believe it's a real condition, but there are many that do not. The majority of urologists do not. And, but what's interesting is we were taught in medical school that finasteride blocks the conversion from testosterone to DHT. But we were not taught that there are 11 other pathways that are affected, not just that one. We were just taught that one. But there are 6 pathways that are neurosteroids, like allopregnanolone. Well, allopregnanolone and these neurosteroids are implicated for depression, anxiety, and when you block them and the levels go down, the depression and anxiety go up. So much so that there have been reports of a significant increase in suicides. In my trial, 2 patients committed suicide out of 25 while being on the trial. And so that was devastating. And so many countries, Canada, UK, have put on the package insert increased suicidal ideation. So personally, I just don't like using that medication.
How about, I think you had it on your slide, but the importance of sleep in cardiometabolic health is just, there's more and more coming out about it all the time. And I think all of us should be talking to our patients about how much sleep they're getting. But isn't there a really profound effect on lowering T if you're underslept, to use Matthew Walker's term? I think it's one of my favorite new terms is, I ask patients, are you underslept? They go, well, what do you mean? And how much are you sleeping? But we're walking around with underslept people all over the place.
Couldn't agree with you more. So listen, when patients come in, I tell them, you have to work with me on these 4 pillars. And if you work with me on these 4 pillars, I will work with you on fine-tuning the hormones. But the 4 pillars are diet, exercise, sleep, and stress reduction. I don't have a pill stronger on the planet, stronger than diet, exercise, sleep, and stress reduction. A majority of our problems can be solved with diet, exercise, health problems with diet, exercise, sleep, and stress reduction. So most of my CEOs, a lot of people I take care of, they do great on diet and exercise. They are lousy when it comes to sleep and stress. And I tell them even how critical sleep is. If any of us on this call tonight sleep 1 hour more efficiently every night, it is a game changer on the next day's productivity, game changer. So remember, it's not the hours you sleep, it's hours times percent efficiency. So if I'm 4 hours, but I'm 80% efficient, and you're 8 hours, but 20% efficient, I will feel better than you. I will feel much better in the morning. So it's not the hours, it's times the percent efficiency. And so it is true, low testosterone, sleep deprivation can significantly decrease T levels. The best studies are shown that if you sleep deprive somebody for 5 days in a row, which is 5 to 6 hours a night, you'll see a 15% reduction in serum testosterone values. But the interesting thing is that the sleep deprivation, if you let them sleep from the second half of the night, let's say from 4 to 8 a.m., and they're sleep deprived from the first part of the night, you don't see much of a sleep reduction in T. But if you actually are letting them sleep well from 12 to 4, but then they get broken up sleep from 4 to 8, that's where you see a reduction in T. So that second.
So that's when your REM sleep is.
That's right. That's the second half of the night is most important. So that's a really important point. So, and then remember sleep apnea. Sleep apnea, how does it reduce T? Because when you have sleep apnea, you get a significant reduction in oxygen. And when oxygen goes down, LH secretion goes down, 1-to-1 correlation. And when the LH secretion goes down, you get less testosterone production. So it's a hypoxic event.
Wow. Sorry to keep asking all the questions.
No
here,
question,
but
no
I hope everybody's getting
No
something out of
problem.
this. We still got people on board here. Let's see. All right, come on, Dr. Bramlett. I know you're there somewhere. You got a question somewhere. Dean is one of the deans of this organization.
Excellent.
Let's see. Rhonda really enjoyed the presentation. Thank you.
Thank you.
Anybody else? We don't have to use up our whole time to 8, but boy, this was a lot of great information in a short period of time. Looks like people are starting to drop out a little bit now. Well, I want to thank everybody for sharing some time with us. Thank Jan for the superb job she's doing at getting and keeping Zila Speaks going, and Dr. Khera, thanks a lot. This was absolutely fantastic.
Wonderful. Thank you so much for the invitation. You guys have a great evening.
All right. Take care. Thank you all.
Bye-bye.
See you next time.